today. Our CME director is unavoidably unavailable, so I'll be anchoring the presentation today. We have a presenter already, and if you don't mind, we'll just give colleagues that are lagging behind a few more minutes before we start. Thank you for joining early. Thank you for putting this, making this priority at this time. So please bear with us for another 2 or 3 minutes. We have an interesting topic today, and I'm sure there's a lot that we will take away from the presentation. Thank you.
It's too quiet.
Unfortunately, we don't have the opportunity of background music. Eh? But yeah. So probably just to make another unofficial CANPAD advert, this year's CANPAD CME will be taking place. CME annual CME and family event will be taking place in Winnipeg. So I'd like to encourage members to register and participate for in the event, and please don't forget CANPAD dues. Thank you. So just one more minute. We currently have about 19 people on the call. This is great. So maybe before we start, I'll just once again like to introduce our speaker. Dr. Muturayo Adetola is a family physician with a special interest in dermatology. He is based in Regina, and he is one of the past presidents and long-term member of the executive for CANPAD over the years. He's been very instrumental to advancing the goal of a CANPAD and establish international presence with our sister organizations around the world and our work in Nigeria. So Dr. Adetola comes with a lot of experience, and he's an excellent resource for us. So without further ado, I would yield the floor to Dr. Adetola to present his topic, topical corticosteroids in common skin conditions. Thank you, Dr. Adetola.
Thank you so much, Dr. Lausubikun. And it's good to be with every one of us again. If I recall, I think this outreach was actually for residents in Egbe, in Nigeria. It's one of our outreaches to them. And I'm not even sure, I don't know if they are online. So it's actually designed for them, but we try to blend it so that those of us who are here in Canada can also benefit. And I remember I was actually the first to give this talk to the residents in Egbe. And that was, I think we started that about 2 years ago. Now, so our topic today, which is topical corticosteroids. We now live in an age where there are newer agents every time, but topical corticosteroid remains a pillar in the management of common skin diseases. I do not have any commercial relationship with any pharmaceutical companies. I have not received any payments or grants to give this talk, and I'm not involved in any research concerning topical corticosteroids. Our objectives here is to identify mechanisms of action and talk about the place of topical corticosteroids in dermotherapeutics and discuss how best to select the appropriate topical corticosteroids as well as dosing, and also the appropriate topical corticosteroids, because the steroids are just as effective as using the right vehicle to deliver them to the diseased skin. Nobody needs to answer this, but it's just something I want us to pay attention to. What percentage of body surface area of the adult does the palm represent? And name 3 vehicle delivery forms of topical corticosteroids that you are familiar with. There are more than 3, but ask yourself, do you know at least 3 of them? Because that becomes useful in choosing what vehicles to use in making your prescriptions of topical corticosteroids. And the other question is, arrange these topical corticosteroid vehicles in the order of their potencies, lotions, ointments, and creams. There you have already answered the earlier question. Now, preamble is that topical corticosteroids are readily available. Some of them are even available over the counter, so patients don't necessarily always need to come, at least here in Canada, maybe in Nigeria too. They are cheap, they are very efficacious, especially once we identify the particular reason why we need them. And they are almost completely free of side effects when prescribed and used appropriately. As primary care physicians, we need to be aware of the potencies that we are prescribing to our patients and diligently explain to them how long we need for them to use it, because sometimes they work so well and our patients think, oh, this is very, very good for my skin. I'll just keep using them for a long time. And then they start using them as if these are their regular body creams. And then that becomes unsafe, at least for their skin. They are very, very safe for use in children. They are safe for use in pregnant and even lactating mothers, especially for those that are of lower potencies, can be used for longer durations. And now, of course, there is the caveat that if they are needed for that. So I'm not necessarily saying that to mean that you can just use them endlessly. But the point is, they're safe if they are needed. The topical corticosteroids are forms of steroids used to control inflammatory skin conditions. And many of their conditions, some of them are not necessarily inflammatory, but we still use them. They are available in creams, in ointments, lotions, gels, foams, and even powders and other vehicles. How do steroids work? How do they perform their work? They work as anti-inflammatories, they work as immunosuppressive, they work as anti-proliferative, for instance, in psoriasis. But their primary work, especially in acute inflammatory conditions, is as vasoconstrictive. In fact, this is how we determine their potencies. What happens is they penetrate the cell membranes and bind to receptors. And by doing this, what happens is that they increase the production of anti-inflammatory proteins and thereby inhibit the production of certain inflammatory proteins or uh, uh, increase the production of inflammatory ones. So some of the things they do, especially in disease states, is that they reduce the constriction of the blood vessels, in the dermis, in the upper dermis, and so help to uh, reduce, all the so-called classic signs of acute inflammation that we see in diseased skin. And that makes them pretty effective, especially in the acute situation. So we can always use them, especially in the acutely diseased skin. And later on, if you want to, you can switch to some of those newer agents that are usually not as effective in the acutely diseased skin. That's what I've just tried to describe. I'm deliberately not going into all those phospholipase, prostaglandins, and all of that stuff. Now, some of the things that are pretty important in um, the use of topical corticosteroids is we need to be very exact about the diagnosis of what we're using them for. As we'll see shortly, I'll show us in some of this slide. One of the problems is sometimes we're not, when we're not sure, some of the doctors, what they do is they use some of these combination drugs that have a steroid in them, they have antibiotics in them, they have antifungal combinations. And apart from the fact that those medications sometimes are pretty expensive, it's like looking for an armed robber, and what you do is you get into the street and you shoot down everybody. Chances are you'll get the armed robber. But what you've done is you've killed a lot of innocent people. That's not the right approach. So an accurate diagnosis is very important. Choosing the correct drug and the correct potency is pretty important. And then also detailing for the patient the appropriate frequency of drug. Many of the lower potency steroid should be dosed. In fact, most of the lower potency topical corticosteroids should be used twice daily, but the higher potency ones can be safely given once a day. Twice a day is okay, but once a day also is a very good idea for many of them, especially those in the class 1 and class 2, maybe even class 3, can be given once a day. These are some of the examples of diagnosis where we found topical corticosteroids pretty effective. Your atopic dermatitis, psoriasis, lichen planus, lichen sclerosis, lichen simplex chronicus, poison ivy, allergic contact dermatitis, pityriasis rosea, and even vitiligo. Now, there's a longer list, to the right of the screen there. So even perianal inflammation, phimosis, but we're not going to go through all of that. But the ones that I made bold are the ones that are where you find the most effective. And these are just certain examples. To the right there is a dermatitis, or if you like, if you're British, you call them eczema. You can see the bilateral. It's almost a photo image. That's the back of somebody's knee. You can see all those scales and erythema with fissuring there. Some of that person has been scratching that skin, and you can see all the lichenification. That's just the increased fissuring lines that you see on both sides there. And of course, to the right there, you see those plaques, grayish or silverish plaques. This is just one type, because we know psoriasis can have different manifestations. So this is just a chronic plaque psoriasis. You can have the gottate type or the erythrodermic or even the pustular types. But the point is whichever, and this is, I'm just showing this in a black skin. It's essentially the same. Of course, the dermatitis here is a bit more acute. You can see a bit of oozing on the right side there. And lichen simplex chronicus in a black skin. This is just people trying to, they just not trying, people just have this urge to itch. You tend to find this in places where people can reach. You're not likely to find this, in unreachable parts of the back, for instance, and you can see all the swelling there, and I'm talking about that lesion on to the left of your skin. And in the middle, the poison ivy, which we have a lot in Nigeria. And even here in North America, it's a little bit rare in Europe. Okay. And then lichen planus, those geometric lesions that's appearing on somebody's wrist. But every time you see something like that, always look in the mouth and also in the genitalia. I'm not discussing those as topics. I'm just showing examples of places where topical corticosteroids can be pretty effective. Now, I only put these two slides in there as examples of places where topical corticosteroids should not be used. To the left there is actually impetigo, and what you do here is you use the topical corticosteroids there. So chances are you're going to make this lesion worse, and that foot there is, oh sorry, I'm already out of it. It's okay. I can go back to it actually. That was actually a fungal infection that has become modified because somebody was prescribing topical corticosteroids. So now what you see there is tinea incognito or tinea incognita. That's the right name. So that's a fungal infection that has become modified because the patient was using or was prescribed or got it from somewhere, was using topical corticosteroid for that. And what you see there is the margins are less raised, less scaly, and it's a bit more extensive than it was. So the thing is, it's become modified compared to the original tinea lesion that was there. So we need to be very careful. We were not sure. You can take skin scrapings here, reassure the patient to wait a little bit more, maybe a couple of weeks. I mean, this has been there for months. So a few more weeks to get your diagnosis, and then you can treat the patient appropriately. Now, the topical corticosteroids are divided into class from classes 1 to 7. Just remember, class 1, class 2 are the most potent, whereas your class 7 is the least potent. Your least potent, for instance, is your hydrocortisone. Your 1%, your 2.5% hydrocortisone is the least potent. And whereas your class 1 will be your 0.05% halobenzone, your diproline. I prefer to just use generic, so 0.05% halobenzone, your clobetasone, your beta metazone dipropionate 0.05. Now, if you look, for instance, in group 3, beta metazone is also there, but that's the value rate, 0.1%. So we need to be, so sometimes you can see beta metazone appears in group 3, group 2, group 1, but the percentages are different, and also the base attached to them are different. So we need to be aware of that. Now, and there we go. So again, we're not going to go through all of that. What I tell people is you don't need to be aware. I tell my students and residents, you don't need to know all of these things. You can always check, but be familiar with maybe one. Of course, we should be familiar with hydrocortisone. That's everybody knows that. Even non-doctors know that. I tend to use beta-metazone valerate a lot, and very rarely do I use clobetasone because that's right up there. Now, I put this slide in. Skineal is very, very common in Nigeria. It's one of those that is mixed with an antifungal. Many Nigerians coming from Nigeria, they pack this, they come with it, when they are immigrating, they pack this. So they will have started, we need to be familiar with this. They pack this, they will have started using it even before they come to see you. So sometimes when a Nigerian comes to see you here, they've already been using their Skineal. So whatever rash they're showing you, it's probably already modified. So we need to be very familiar with that. And if we have some of the Nigerian doctors out there, it's not a good idea to be recommending Skenel for your patient. Try and make your diagnosis, arrive at a good diagnosis first before you start recommending drugs like Skenel. Now, the one to the right there is a combination of beclomethasone, which is a topical corticosteroid, clotrimazole, an antifungal, and neomycin, an antibacterial. Again, expensive for no reason, and it is trying to treat every skin disease with a cream, which doesn't make sense. You know, chances are the patient doesn't have uh, an, a fungal illness, bacterial illness, and then an inflammatory skin disease all at the same time. So we need to be very careful about prescribing this kind of drugs. So, here, the point I'm trying to make here is we need to be familiar with the drugs we're using and their potencies, you know, which of course is conferred by their vasoconstrictive effect. Now let's just look at the vehicles a little bit. So ointments are most suitable for dry and scaly skin, you know, maybe the palms, the soles of the feet, and for non-hairy, scaly, non-hairy skin, and maybe places like, you know, hidden places like the leg. You shouldn't be prescribing ointments for people's faces because they are a bit occlusive, you know, and they come with side effects when you use them. It's funny because remember growing up, we were always using Gelene and Vaseline ointment, you know. Uh, and those things, what they do is they can cause what we call a pomade acne. You know, pomade, of course, is French for, you know, something occlusive, you know, that's an ointment. So don't prescribe ointment for lesions on people's faces or in their axilla. The skin of the axilla or intratriginous places and your face are the thinnest. So if you are writing a prescription for whatever, you know, betamethasone valerate 0.1%, don't write the ointment, you know, for a lesion on the face or in the axilla or under your patient's breast, you know. Now, they penetrate the skin better than creams, and it's just that I would rather use them for places like the palm, thick places, dry, especially skin of the palms and soles, you know. But remember what I said, not for thin skin. The creams, they spread easier. They are more aesthetically acceptable to patients, and they're much less occlusive, and and also they're much more useful in acute situation. You know, if you have a skin lesion that is very wet, so they're just generally more acceptable to patients. You know, so you can apply them really anywhere. You know, but just remember in terms of penetration of skin, they are just not as good as the ointments. Okay, and of course they are much more acceptable. Lotions are much more acceptable in places that are hair bearing, you know, like the scalp. Now, you try and apply ointment or cream to the scalp, it just doesn't go well. So lotions work much better on the scalp. Now, of course, that probably doesn't work for somebody who is completely bald. So if somebody's completely bald, then it doesn't matter. I guess you can use cream on there. So for instance, your betamethasone valerate will therefore comes as ointments, creams, lotion. So if you are prescribing for for a condition that is on someone's scalp, you can prescribe your betamethasone valerate 0.1% lotion for lesions on the scalp. And if that person, so if somebody has psoriasis, for instance, you can prescribe two, the lotion for the scalp, the cream for the body. That's the point I'm trying to make here. There are foams also. Foams also work pretty well for for lesions on the scalp, but foams are a bit more expensive. And gels are a bit more. Gels are also available, but they are a bit more drying. So just let's remember that. Now, when you're prescribing for people who find things a bit more drying, you can always encourage them to use maybe a moisturizing cream before applying the steroid, or even after it, just to help reduce the drying effect that they may be experiencing. Now, one of the other questions is people say, I don't know how much to prescribe. So there has to be a bit of formula behind knowing how much to prescribe. How much do I prescribe? Now, so this is where we use the fingertip unit. The fingertip unit really mirrors the, for adults at least, we can now derive from that, the formula of 9 that our surgical colleagues use to manage patients with burns who have suffered burns. Now, the palm of an adult, the palm, excluding the places where there are fingers, the palm is about 1% of the total body surface area. And that is using the rule of 9, really. So the torso in front is about 9%, same thing for the back. The arm is about 4.5%, and and on. So if you do the math, the head is about 9%, 4.5 in front, 4.5 behind, and on. So if you do the math, using the rule of 9, what we tend to do is you calculate the area involved with the inflammatory condition that you want to treat, and then that from the tip of the finger to the distal interphalangeal joint there, just as you see, if you assuming your, assuming you're putting the cream just in that fashion, with the, if the steroid is in a tube with a nozzle, and you're putting it from the tip of the finger to the DIP, distal interphalangeal joint there, it comes down to approximately 0.5 grams. It's a little bit more in a man, 0.6, 0.5, but we just assume 0.5 grams. Now, 0.5 grams of the cream or the ointment will be sufficient for 2% of the total body surface area. Remember that 0.5% of the cream or the ointment is sufficient for 2% of the surface area. So we call 0.5 grams the equivalent of 1 fingertip unit. That's what you're seeing on your screen there. So 1 fingertip unit is 0.5% of the cream. So let's just work on an example here. So if 0.5 grams covers 1 fingertip unit, and that is sufficient for 2% of body surface area. So if I'm trying to find out the percentage that I'm using here. So if we have 10% of body surface area affected, so it means we're going to use 2.5 grams. So that means you're going to need, so 2%, so 0.5 covers 2%. And there are 5 of 2% in a 10% surface area. So that means you need 0.5 times 5. Okay, so it means in one day, you're going to need, it means you're going to need 2.5% per application. So in a day, since you're assuming you're using one of those lower strength, lower potency steroid, so you need 2.5 grams per application. In a day, you're going to need 2.5 in the morning, 2.5 in the evening. That's 5 grams. So if we're applying for 14 days, you need 5 grams times 14 days. So that comes to roughly 70 grams in a 2-week period. So you can estimate and say, okay, let's give 70 grams. So when you are prescribing, you can say, prescribe betamethasone valerate 0.1% cream topically BID for 14 days. And you can tell your pharmacist, supply 70 grams. It's an estimation. If it's right, 60 grams, you're not too far off. That way, the patient is not going to come back after 5 days and say, because if you just wrote 30 grams, then patient is going to run out pretty quickly and get angry because now they have to pay another dispensing fee. That's not right. Now, there are other things that doctors write. They write something like apply thinly or use sparingly. No, you have to say to them, they have to apply enough. In fact, what they do is, the instruction we should give to our patient is to say, apply apply gently until the cream or the ointment disappears. And they should keep applying until the consistency of the skin comes back to normal. Normal, they can always compare to the regular skin. And they should keep doing it. Usually I'll say, uh, one of the things I tell my patients in the office is they should take a picture of the diseased skin, so that, because it's always difficult to say, oh, last week, what was the skin like? And so they can compare it at the end of 1 week, at the end of the second week, but really, they can keep applying, say, for 2 to 3 weeks, and then compare, especially if they've taken pictures. Everybody carries a camera around now. I think in the penetration of using of cell phones in North America now is about 85–90%. So everybody carries a camera. So we should tell them to apply enough to cover the affected area and rub it until it essentially disappears. So they can apply their steroid once or twice a day, once for those in group 1 to 4, the class 1 to 4, and twice a day for those in classes 6 and 7. They can apply for up to 12 weeks for those in the up to 12 weeks for even those in the medium potency and high, not the super potent. And the fear of adrenal uh, suppression is often overemphasized, but the truth of the matter is once they stop, the likelihood, those things tend to, it's very rare, number one, but even if you were to notice it, and what to look for is look for hypotension, confusion, decreased pubic hair and all of that. Those things tend to stop. But like I said, it's very, very rare. I haven't seen one. The other thing to always emphasize, especially when we prescribe corticosteroid for a patient, is to emphasize the use of emollients, moisturizing agents. I don't care which one, whichever one you're comfortable with, whether it's Aveeno, CeraVe, Cetaphil, Eucerin, Glaxel base, Aquaphor, Kerry lotion, whatever. And for tough skin, the palm, the sole of the feet, petroleum jelly, let's encourage them to use them. All right. And always review the diagnosis. If the patient is not getting better, tell them to come back. Don't just prescribe and tell them to go into the sunset. After prescribing, you can tell them to come back in a couple of weeks so that you can review whether they are doing well. Sometimes we may have chosen the inappropriate vehicle, so we need to be aware of this. Non-compliance, because I've seen patients come and say, well, I used it for a day or two and it got better and I stopped. Probably not sufficient, because steroid, even though they kick in faster than, a Cristabol or a Elidel, 1 day or two is most likely not sufficient. And then let's not forget, we may have made an incorrect diagnosis. We're not God. We don't know everything. So we always need to review the diagnosis we made so that we can be more accurate in making and make the right prescription where necessary. And let's not forget we have alternatives. Very often, what I find, especially in acute inflammatory conditions, is that things like medications like Protopic, Elidel, and Cristabol, they are effective. Of course, they are much more expensive than steroids. But I find out that in acute situations, they are not really, they don't kick in. I mean, that's the reality. They don't kick in as quickly. But in the long term, they can be very effective, especially because of the fear of the side effects, like striae and thinning of skin, which are real. Don't get me wrong, are real. I'm not trying to undercut that. So we can get things started with topical corticosteroids. And once things flare down, we can continue, especially for those patients who have chronic conditions like eczema, dermatitis and all that, with these medications, once things have flared down. I'm not I don't want to go into the discussion of this particular medication. That's not the topic today, but there's a place for them, especially for those who can afford them. But we cannot underemphasize the fact that once we tell our patients to use the right soap, they shouldn't use too much soap and use their emollients, use it religiously, twice a day if necessary. Very many times we may not need to use all these more expensive alternatives. So summary, make the correct diagnosis, take the time to instruct our patient on the place, the safety, and the effectiveness of topical corticosteroids, use and deploy the right molecule and right topical corticosteroid potency for the right duration and strength. Avoid using topical corticosteroid, antifungal, antibacterial combos, especially when we're not certain of what the diagnosis is. It's always a good practice to know how much to prescribe. I've had a patient who disagree with me because she says, "Oh, my former doctor used to prescribe 200 grams of clobetasol. This is class 1 for me." And I said, "Well, I'm not going to do that." She says, "Yeah, that's what, and for what?" It's because she has eczema, which flares up every now and then. I said, "No, I'm not doing that. 200 grams. It's just not something I'm going to do." She doesn't have a lot of flare-ups. She has it once every 6 months. Her skin is pretty good. And I said, "No, I'm not going to do that. If you're not happy, you're not happy." I don't know. I haven't seen her for a while. She probably wrote a review, but that's okay. I'm good with review. It's good practice to know how much to prescribe. So where we're not sure, it's okay to contact our dermatology friends. They will help us out. I thank you for listening. This is our answer to questions. The percentage of body surface area of the adult palm is 1%. These are some of the delivery vehicles: ointments, creams, lotions, gels, foams, oils, solutions, even shampoos. The 3 vehicles arranged from the lowest to highest. Lotions are the weakest. Sorry, that's the question. Lotions are the weakest, of course, followed by cream, and ointments are the strongest in terms of their potencies,
Thank you very much, Dr. Adetola, for that wonderful and practical presentation. I, as a surgeon, I even found this very, very educational. I come across patients with lichenification of the skin and chronic dermatitis from chronic venous hypertension, varicose veins in the lower limb. And so I've taken a few notes here and things that I can apply to my practice. I also want to thank you because your presentation was EDI compliant. Your images showed pathology in patients with a different skin tone. And I would like to encourage all of us to make note of these subtle things in presentations that we attend, and make note of those, comment on these things, be it formally when you're writing your review of the presenter, because these are some of the things that we have to be doing now in 2024 to make our curriculum EDI compatible. And if we don't address those or comment on those, we won't see the necessary changes. So thank you for those things. Just one comment from me before I open the floor. I know that you're a very compassionate physician, but when you talked about your last patient that you had a dispute over the dosage, I'm sure you educated the patient before putting your foot down on why it's important not to just take 200 grams instead of what is needed. I think that's critical in our conversation with our patients, irrespective of their background. Having some level of communication that is professional and that leaves us at least in a defensible position. Peradventure, something comes back at us. Your thoughts on that?
Oh yeah, oh no, absolutely. The thing is, the point I was trying to make was you come to that after you've tried to educate on why
Yeah.
it's not safe because this particular drug I was talking about is a class one drug. My fear is this person is going to be using it. 200 grams is a big jar. It's a very big jar of this drug, and I just don't see. There are situations where I will write that it's not really the size for me. It is the fact that I just don't see the indication or the reason for whatsoever to write that size for that person. And
Yeah.
after educating and this person is putting, I mean, and she has the right to put her feet down. And it's like, no, I'm not doing it. And I'm not going to be forced into doing what I just don't feel
Yeah.
comfortable
Yeah.
doing. So it's like, no, and that's fine. She's not going to accept. Now, I saw a comment flash by someone says, asked that I go over how to determine the dosage,
Yeah.
the how much to prescribe. So like I said earlier on, from the fingertip units, the way we
Do you
describe
mind
it
going
is
back to that slide, sharing that slide
okay.
for
Yeah, let me
the
go back to it.
dosage? I think part of the confusion for me was you were using percentage when you probably meant to use grams.
Oh, okay.
So
All
yeah,
right.
so
Okay.
if you
Actually, I think I can do it without a slide. So
okay,
once you've made up your mind, let me give you an example. Let's say you want to prescribe 1% hydrocortisone cream, which is actually not even a prescription drug, it's over the counter. So let's say you've made up your mind, you want to prescribe 1% hydrocortisone. Okay. So now the question is, what is the bulk? how many, what's the,
tubes.
someone help me here.
How many tubes? What's the quantity you are going to
Yeah, what
prescribe?
quantity? Yeah, we're trying to determine the quantity. Thank you. That's the word. So, so you've decided. So now the question is, what quantity? So let's say we want to treat for 14 days, and the area affected. So this person has 10% body surface area affected. You've done your calculation. This person has a total of 10%. So you've done your calculation on this matter, and this person has 10% of the body surface area affected. Okay. So remember one fingertip unit of that drug. Okay, I'll come to that one. So one fingertip unit of the drug is enough for 2% of the body surface area. We determine that. And one fingertip unit is equivalent to 0.5 grams of the drug. That's 0.5. Okay, so if it is a 10% body surface area, it means you are going to need 5 times of 0.5. Okay, so it means we're going to need 0.5 times 5. That comes to 2.5 grams per application. And since we're going to apply this drug twice a day, that is 2.5 grams in the morning, 2.5 grams in the evening. Okay, I'll go back to the slide. Somebody is saying show the slide. 1 second, ma'am. Sir.
Yeah, the slide makes it.
Yeah.
And the presentation will be available.
No, actually, I've
Um,
done better. I've recorded this and I'll convert it into YouTube.
Excellent. So we will have we'll be able to access this information.
Okay, so just I'll go over it again. So if so I mean, most times when your patient picks up, some of the pharmacists don't even give it to them in a tube with nozzle. All right, but this is, so we're making a pretense here. So assuming it comes, but sometimes it comes in nozzle form. So assuming it comes in a nozzle, uh, from the fingertip, from the tip of the finger to the DIP, there is equivalent of 0.5 grams. And we know that 0.5 grams of that cream or ointment is sufficient to serve 2% of the body surface area. Okay? So using an example of a patient with the disease affecting 10% of their skin. So we know in that case, so if 0.5% of the cream or of the drug, whether it's the cream or the ointment you've decided to give, if it is enough to service 2% of the body surface area, and this patient in front of you has 10% of his skin or her skin affected, that means the patient will need 2.5 grams of that drug for 10% of the body surface area, because 0.5 grams is good for 2%. It means 2.5 grams will be good for 10%. That's just 5 times. So that is per application. So you give 2.5, you're going to use 2.5 grams of the drug in the morning. So for the evening, you're going to use another 2.5 grams. That is 5 grams in that day, in that one day. So now you're going to use the drug for 14 days. So that is 5 grams times 14 days. So it means when you're making your prescription, you're going to say supply 5 grams for times 14. That's 70 grams of that drug. So if it's hydrocortisone, you're going to say you're going to prescribe hydrocortisone 1% cream, apply BID for 14 days, supply a total of 70 grams. If it is betamethasone valerate, 0.1% cream, is going to be applied topically BID to affected area for 14 days, and you're going to say 70 grams. We can apply it. Okay, let's say it's 20% of body surface area. So if it is 20% of surface area that is affected, so
140
it's
grams.
still 0.5 is still 0.5 for 2% body surface area. The only difference this time around is it's going to be 0.5, which is good for 2%, but this time around is now 10 times of that. So every time you apply the drug, you're going to need it. You're going to need 5 grams. 5 grams in the morning, 5 grams in the evening. That's 10 grams a day. For 14 days, that's 140 grams. That's the meaning. So you're going to ask the pharmacist to supply 140 grams, but give or take, that's the meaning. So, but if the patient needs 140 grams, and all you do is you just say, oh, supply 25 grams, that patient is going to come back in 3 or 4 days, because it's a wide area of application that is needed. And the patient is going to have to pay the pharmacist another dispensing fee. So we need to be careful about that.
Thank you very much for that explanation. And so bottom line, getting your calculation right,
Yeah.
you're getting the quantity right, so that it is a once-off visit to the pharmacy for the patient. And it saves it notifies the pharmacist how much you want the patient to have, and it saves the patient that dispensing fee peradventure they need to go back for another treatment when you could have done that all at once. So thank you for that clarification. Yeah. Another question in the chat there from Dr. Adeni. Is the vehicle of administration a consideration in duration of usage, aside being important as the body part the drug is being administered?
No, really, no. It's the importance is where you are trying to apply it. That's once you've made up your mind. If the lesion is on the face, for instance, a cream is what you want to use, rather than an ointment. It's how long is not the matter. But of course, you definitely don't want to use for much longer than is needed. I don't want to use an ointment on anybody's face because you're likely to add to that person's problem.
Okay.
Some of the things I didn't get into is the intratriginal areas, armpit, under the breast, in the groin. Those places, because people tend to sweat in there, the absorption of steroids in those places is highly increased. In fact, the difference between some of those places, your face, the intratriginous areas, compared to like the sole of the feet, is a difference of about 300 times. So if you have to treat lesions in those places, you want to use lower potency steroids because the
Okay.
absorption is very high in those places. So if there are lesions there, don't use moderate potency or high potency steroids, okay? Because then the fear of side effects of topical corticosteroids in those places is high if they use for too long. Uh, Places that are moist, moistness generally helps the potency of steroids. Let's remember that.
You want to say that again?
Moistness, moist skin. In places that are moist, steroids tend to be better absorbed.
Okay. Okay. Will that be because there's increased blood flow, inflammation,
Yeah,
or
skin becomes more porous. That is one of the
more
reasons why
porous?
if you have a patient with a horrible infection or horrible skin issues, horrible, sorry for my English. One of the things we can do is we do occlusion. So if you have a patient with a very bad dermatitis, for instance, one of the things you can do is we call them occlusion. You can soak maybe their pajamas and put their pajamas in warm water, then maybe put it inside a towel and they squeeze it dry, then apply the steroid and make them wear the pajamas for maybe a few hours. That actually helps the steroid to penetrate better.
Wow.
Yeah.
Okay. By the time I need to do that, I'll be referring the patient to you.
Good
So,
morning, Dr. Adetola. Sorry, go on. Yeah. Sorry.
yeah, go
Yeah, go
ahead.
ahead.
Go ahead.
Yeah. Sorry, good morning. So this is Dr. Abdul. Thanks for that very nice and very informative presentation. Sorry, I was just going to say something. Though one thing I just realized is I would say probably I don't prescribe steroid cream, or that's probably not part of my practice. But it's actually very challenging when you're saying 200 grams. Do you mean 200 grams or 200 milligrams? Because the normal physiological response of the body, the adrenal in a normal person is about 5 milligrams per day. So when you give someone steroid like 5 milligrams of prednisolone for 30 days, after 30 days, you can actually cause secondary adrenal insufficiency. So you only need about 150 milligrams in a month. Anything after that, then that's why you can you can cause adrenal insufficiency, and that's when people become hypotensive. You see hyperkalemia, hyponatremia, and all the rest. So for someone requesting 200 grams, that's massive amount of steroid. There's no way, you only need even a week before you suppress them. So that's very interesting for someone asking for clobetasol, which, as you said, is a class 1 medication. And so I think thanks for this. I actually didn't know the percentage and how much steroid is in all those percentage and all those prescriptions. Thankfully, I don't prescribe them, but thanks for this information, because that's very, 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 how do I say this? It's very, very, it could be very, very critical and very calamitous if you prescribe such massive amount of this thing, because the patient can end up in the hospital. Thank you very much.
Thanks so much, Dr. Abdul. And that is very true. I'm sure we have a lot of family physicians there, and many of them would probably say, I very rarely do they write even 100. I have one patient in my practice who gets 100, but that would be like once every 6 months. This poor lady, she has very severe dermatitis, and it wasn't even instigated by me. It's because the dermatologists have sort of passed that over to me. She was a victim when she was much younger of, according to her, aeroplanes that sprayed farms. And I think she was in the farm, she was younger, and they sprayed some chemicals over their farm or something like that, and she was doused with it, you know. And so since then, she's had this recurrent skin issue. So the dermatologists were the ones who started out on it, and so I've sort of inherited, and I'm maintaining. So she gets 100 grams of it. But you are absolutely right on that. Thanks. The other thing, though, I also want people to recognize is the skin, thankfully, actually also takes part in metabolism of topical corticosteroid. Even the diseased skin does that. So potentially the skin is a sort of a gate which takes part in metabolism, even at that level, and prevents a lot of steroid from even getting into the HPA axis, and therefore protecting us from some of the calamitous things that can happen. But that said, in my office, my average prescription of steroid will be something like 50, 60 grams of steroids, when they go to the pharmacist. Because most of the time, rarely would I get maybe an erythrodermic condition, which will involve, well, 80% of the skin. Most of the time, they have a rash here, a rash. If you look at some of those pictures I showed, I presented. I mean, for you to have a condition where, when I said 140 grams, 140 grams is 20% of the total body surface area. 18%, the whole front here is 9%. The front of our torso is 9%, and the back 9%. That would be 20%. If I'm getting somebody whose skin is covered, the whole torso, 20%, I probably will be hitting the phone and saying, the dermatologist, please, I need you to help me see this patient. I will be begging them. So that would be a reason why I would say somebody should get 140 grams. I probably won't be handling that myself. And then that's also getting into territory where I will probably be saying, maybe I should use oral steroid for this person. But then oral steroid is also getting you into something, because at the end of the day, oral steroid is in multiple terms giving that patient much more steroid than topical corticosteroid would actually give over that long period of time. We need to recognize that. Topical steroid is a lot of steroid, but nothing compared to what you will be giving the patient when you're giving them oral steroid. Thank you.
Yeah, that's actually very true. Yeah, with corticosteroids orally, you get even up to 70 to 80% absorption. But with your skin, it's actually about 20 to 30%. But just as you've said, places like our groin, our armpit, it could get up to 40%. So and when you have a lot of inflammation, you actually get more absorption of steroid subcutaneously or intradermally as well.
Absolutely.
Thank you very much.
Thanks.
A few other comments or questions in the chat. Dr. David says, thank you, sir. Does this apply to every class of topical medication? I don't understand the context. Do you grasp that, Dr. David?
Well, I think, it's not, no, I think I understand what this person is asking. No, the answer would be a no. Steroids are the ones that are particularly unique in how dangerous they can be.
Okay. And the next comment from Dr. Timitokwe, does this apply to all forms of vehicle and strength?
Remember, what we're trying to say is one drug can come in different vehicles. In fact, one drug comes in different vehicles, but one vehicle can make the same drug more potent. So betamethasone valerate, for instance, comes as ointment, comes as cream, comes as solution, comes as foam. But even though it's the same drug, the same percentage, the ointment, if you put it side by side with the cream and the foam and the lotion, the ointment is more potent than the rest of it. And only because it's like, only because the ointment, potentiates the activity of that same drug because of the vehicle. That's all.
Okay. I hope that answers your question, Dr. Temitope. And Dr. Ife here says, please, what is the process of skin scraping, collection, and sending for diagnosis?
No, that's actually pretty simple. If you ask your local laboratory, they will supply you with this paper. It's like that. It's paper, but it's black. It's actually black. There's no trick to it. And all you need to do is you can use your surgical blade to scrape the skin. You just scrape, you know, you just
Okay.
scrape and collect the skin scraping, put
Exfoliates.
it in there, label it, and send to the lab. That's all. I'm
Okay.
sure if you go on YouTube, you can take a look at it. It's the same way you collect skin nails. In fact, it's the same paper you collect if you are suspicious that your patient may have onychomycosis, you cut the nail and put it in. It's the same paper you use. You collect it in it, put your label, and complete the requisition form and send it to that same lab. And then
Okay.
some weeks later, you will get your results back because
Okay.
they will do your potassium hydroxide microscopy, and if you have also ticked that they should do microscopy, they will do it, and you can get your results all back.
Wonderful. Please, what about children? Dr. Anita is asking, please, can you let us know what type of steroid cream you use depending on the area affected and the
It's
total body
actually the
surface
same.
area?
It's actually the same rule. The only difference was, and I was actually going to include that in the talk. So for children under 10, but people 10 and older is the same quantity of strength. Sorry, the same quantity we give them. So it's not about the potency. The potency we use the same. Except that for babies, of course. Uh, I mean, if I have a baby who has very bad inflammatory condition, I probably will use your lower potency steroid,
Yeah.
the 1%, the 2.5% hydrocortisone. I'm not likely to want to use clobetasol for those
Okay.
ones, but I've had situations where I've had to use something like betamethasone valerate. Now. Um, But if I have to do that, I may have to call the dermatologist to just get their opinion. But I've never used clobetasol, which is like class 1. Now, but in terms of the quantity, because they are very tiny. So for people less than 10, then I'll probably use something like 75% for people like between 6 and 10. Maybe after using the same rule of 9, I'll give like 75% of the quantity calculated. And for 4 to 6, maybe 50%, and then 25% for people less than 2. I'm just talking about the quantity now. Remember
Okay.
how we calculated the quantity?
Yeah.
That's the way I'll go.
And how does that now affect the duration then
No,
of
no, the
treatment?
duration is the same.
Okay, but they will use your measure now will be the palm of that patient,
Yeah, no, it's just
not
difficult to,
not the
I'm just saying I'm not going to, if I calculate, if 10% of body surface area of an adult, if I'm going to use 60 grams if I'm going to prescribe 60 grams for something I calculated to be 10% of an adult, a full-size adult, I'm not going to also give 60 grams for a 2-year-old. That's what I'm saying. I'll probably give
Okay.
20 grams for that one.
Okay.
Yeah.
All right. And there's one last question here from Dr. Annie. Please, on which situation do we have only the last option to prescribe steroids if there are lesser side effect drugs out there?
Sorry, I didn't get the question.
Dr. Annie, do you want to unmute and ask?
Okay.
Yeah,
Good day from here.
thank you.
I'm so much happy to see you people.
Thank you.
So I'm saying It's like a steroid. It's just like a higher class of medication when you might have tried other drugs, right?
Yes.
Then want to use like the final bullet to shoot this to shoot your enemy, right? So, in which situation do we have to use a steroid, both children and adult? Maybe we have tried other medications and it doesn't work. So, in which situation do we have the last option to use steroid?
Oh, okay. All right. No, okay. I understand the question. No, in the when I started the talk, I actually gave some examples of situations where steroids are necessary. So if, for instance, patient has dermatitis, um, um, pityriasis rosea, psoriasis, and on. Okay, you know what? Let me actually show you that slide. So it's not in those cases. It's not even up to situations like let's try this and let's try that. Uh, this slide here. So atopic dermatitis, psoriasis, lichen planus, lichen sclerosus, lichen simplex chronicus, poison ivy, allergic contact dermatitis. We are not really left with a lot of choices in this situation. We're just going to go straight to topical corticosteroid because in many of these situations, if you don't use topical corticosteroid, you're going to have to use things like either oral steroid or maybe your protopic, Elidel, and all of that. But in this situation, the first thing to probably go to will be your topical corticosteroid because they are cheap, they are effective. They are known to be effective in these scenarios.
All right.
Okay, thank you very much.
Yes.
Dr. Awubem, you have your hand up there.
Good morning, everyone. Thanks, Dr. Adetola. Wonderful, brilliant presentation, always educative. Like Dr. Laoshebikan said, occasionally, I know some people might wonder what's ENT got to do with skin. Trust me, a lot. But we actually interface with dermatology a fair bit. I just want to say, I mean, just to beg to say that some of the general skin, so in ENT, for example, you get unfortunate patients who have eczema involving the outer ear. It's actually one of the causes of recurrent otitis externa, which can be quite frustrating to our family physician colleagues out there. They tell you that, look, I've been treating this ear infection for the last 4 months. It keeps going, it keeps coming, it keeps going. Just to point out that it's either, most often it's either eczema, it's also called diffuse otitis externa, or rarely, much less commonly, it could be psoriasis, but by far it's eczema. So eczema typically would involve maybe the limbs or the torso, but you can't have it involving the outer ear canal. And sometimes that's the only area involved, quite unfortunately. It's important to know that you can't cure it. So yeah, they will get repeated infections if they don't take the good care of the skin of that area. And yes, it is one of those situations where as ENT will advise very mild, actually over OTC, over the counter, say hydrocortisone 1% for the ear. Also, it's one situation where I know there's controversy whether the ear is part of the face or not, but usually we would say ointment. And in that instance, too, it's a bit difficult to use the rule of thumb, the rule of the finger. So you still find a number of ENTs will still apply the term use sparingly. Forgive us. That's the reason. It's a bit difficult to measure the outer ear canal. Occasionally, we say use peanut size. Peanut size is approximately 1/5 of the 5 gram that was shown. So you can either say use peanut size, since most people relate to what the size of a peanut is, or we still say use sparingly over the area. So just in case I advise that, don't take it that I'm going against what Dr. Adetola has brilliantly presented to us. Yeah, I was also going to, a few of the other things I was going to say has been taken out of my mouth. For example, in children. So the formula for calculating body surface area in children, especially under 2, is very different. You can actually Google it to see the image. It takes me back to my many years ago. I did plastic surgery and did a stint in burns, in the burns unit. We did the body surface calculation every day. So you can easily Google if you're not sure, but Dr. Adesola gave a rough formula. It's a rough guide, like they say. There's a movie called The Hitchhiker's Guide to the Galaxy. It's a rough guide trip to Mars, if you like. But it works brilliantly. But if not sure, you can always Google the image. Yeah, so we do use steroids occasionally in the nose, occasionally in the ears, and you might have to bend that rule slightly because these areas are a little bit difficult to quantify. Otherwise, brilliant presentation. Thank you very much.
And thank you so much, Dr. Awobem. Just to add to what Dr. Awobem has just said, you see, I live with a gynecologist, and just similar to what he has just said, for lichen sclerosis, they also use this pea-sized dose of class 1, really, well, class 1 or class 2 steroid, clobetasol to be precise, class 1, for their patient with lichen sclerosis. Okay, and so by I don't even think when they train their residents, gynae here, they ever talk about thing like all these fingertip unit is a standard clobetasol 25 grams standard rule. That was the way they were trained. That was what they talk about. So the day I started talking fingertip unit, she's looking at me, said, just write 25 grams now. So I'm looking at her. I said, so you think all my patients have the same size as your patient's your patient's vagina? I should just write 25 grams for all my patients. And we had a good laugh out of that. Yes, so and it's because they use pea size. But sometimes my patients have extensive rash, and that 25 grams is what they will use in 3 or 4 days. So we need to be cognizant of patients like Dr. Awobem's patients or the gynecologist lichen sclerosis. I mean, some of our patients will probably use 25 grams for a whole year and still have some of the steroid creams or ointments, and they will still have half of their jar left. Thank you.
Thank you very much for those comments and questions. Just one quick one. Is there any relationship between lichenification and leukoplakia and the potential for malignant transformation?
Between lichenification?
Leukoplakia.
Lichenification is just a description of the skin lesion. It's not a diagnosis.
Okay, beautiful.
Yeah,
thank
leukoplakia, yeah, so yeah, well, anyway, it's one of those primary description of skin lesions, which you can find in any. So usually, lichenification just means that skin lesion has been there for quite a while, and it's one of those things you see when patient has been scratching the lesion, and then the skin becomes thickened, and then you see it becomes more linear. The lines are much more prominent, so we say, oh, this skin has become lichenified.
Okay, thank you very much.
And leukoplakia just means that that lesion is becoming a little bit more whitened, so in its appearance. Even leukoplakia is not necessarily a diagnosis.
Okay, super. I appreciate that. Thank you very much. Well, it's about 10:15, and
by the way, I have to remark before you go that thanks for the attendance. There was a time we were 80.
Yes, I was monitoring that, and I was about to say that. Thank you, CANPAD members from all across the country for joining in. Just like Dr. Adetola had mentioned, this monthly CME session started with a view to reaching out as an outreach to Nigeria. We had selected the Mission Hospital in Egbe. They had shown interest. It started during COVID, and it was supposed to be one of our contributions to their work there. And the plan was to transition to in-person visitation to help with the work there. At this point, the management at Egbe Hospital has changed. And this does not appear to be their focus right now. But interestingly, members of CANPAD have taken an interest in these CME sessions, and it is great to see how many people have committed a very vital part of their hour on Saturday to this event. So thank you very much, everyone, for coming. What we are working on at the end of the day is to ensure that we formalize this process. We have CME points that we can gain for each topic. It's just takes a little bit of leg work, and I'm hoping that before or by the time we finish CME family event in Manitoba, we would have also formalized this as well. But that being said, you can still gain about 0.5 points if you submit this time and topic and your learning objectives in your CME yearly CME what do you call it need. So thank you everyone for joining. Having 80 people is very encouraging to the presenters, and we hope to see you next month when we have another session. So unfortunately, I don't have the calendar with me, so I can't give you a heads up as to what's coming, but watch your regional or central CANPAD WhatsApp forum for the next advertisement on this presentation. Have a wonderful weekend, everyone. Thank you.